cost sharing reductions, from a standpoint of just the impact for the individual consumers, it's a way to lower premiums and deductibles and cost shares that they may experience on the health insurance exchange. And if they were removed, the concern would be is just the perhaps increased out-of-pocket costs for consumers. It might increase the overall premiums. They provide a little bit, I would say, of a stability to the market in terms of pricing. So figuring out how to pay for that health insurance is probably last thing when a consumer is trying to figure out. They're looking at price, but they're not looking at the cost savings reduction. They're just looking at that price that comes up on healthcare.gov. So CSRs are kind of baked into it, and they allow that cost to be hopefully more affordable for the consumer. So if they remove the cost sharing reductions, my concern would be the opposite, that it would actually increase the number of people without insurance, because it would make it probably harder for individuals who may be under a certain federal poverty level. Their ability to afford insurance would probably be impacted. Well, if for instance, the number of people who might be impacted by whether or not a cost-saving reduction is part of their premium or somehow will impact their price, if those people then become uninsured, then what happens is that we all experience, I think, the impact of that through something called uncompensated care. So if I don't have insurance, I'm going to the emergency room to get my care. A lot of times that care, for instance, could result in an inpatient hospitalization stay, could result in pharmacy. People without insurance do not have that kind of ability to provide or to get or obtain those type of services and benefits. So the cost savings reduction in part allows someone to have health insurance, which will in turn help keep the overall cost down for the entire healthcare delivery system. What is called freestanding ERs are really ERs that aren't really, if you think about an ER today, you usually go to a hospital, it's attached to the hospital. These are actually standalone brick and mortar type facilities that will provide ER care. So I think the overall intent of them were to provide more access to ER services. That sounds like a good thing. I mean, you want people to have access to the ER for life-threatening situations. However, what we've seen here in Ohio and across the country is that our use of the ER for what we call non-emergency situations has proliferated. We have probably the highest rate of what we call non-emergent ER utilization in the Medicaid program in Ohio. We struggle with that daily because we want people to have access to an ER, but we also want them to establish what we call a primary care health home. So that way they can get care from their physician. What we're seeing as a result of these what we call freestanding ERs popping up around, and even Central Ohio, I think, had about 16 announced over the last year and a half, is a concern that you're creating these access points for a very high cost place of service. So instead of that person saying, you know what, I can go to my doctor, I have to schedule an appointment, I'll just go down the road to my freestanding ER. And I think a lot of people think freestanding ERs are urgent cares, and they're not, and that causes a problem too from a consumer standpoint. If you're looking for quick care on the weekend, you see a freestanding ER, you might think it's urgent care, and it's not. It's actually billed at a very much a higher rate, and those overall costs contribute to the overall cost of health care, and those costs get shifted on to various other delivery segments in the marketplace. So we really want to encourage people to actually access their care through their doctor, not go to an ER, but then also try to figure out a way to really educate consumers and the public about when you use the ER and when you don't. So 1332 waivers was a discussion point today, and what we talked about was how that might be used to give states more flexibility in terms of basically creating a more stable individual market, maybe addressing some of the things that are being discussed at the federal level, like waiving the individual mandate. So from our perspective, I mean, what we see this is an opportunity for the states to have more control over the delivery of health care in their own neighborhood, so to speak. You mentioned Seema Verma. Seema is the head of the Centers for Medicare and Medicaid Services, or CMS as we commonly call it. And she came to that position, she was formerly with the state of Indiana. She was their Medicaid director. And while she was with Indiana, she created a waiver called Healthy Indiana. And the idea is that you're going to create a Medicaid program, so you're going to take an entitlement program and really turn it into a program that's going to help people get back on their feet. So how do they become more, once they get their health concerns addressed, get connected with a job? how do they then start to transition into what many of us have as a common insurance product? For a lot of people who've never had insurance, what we find is the challenge is just teaching them how to even access insurance. Like, this is your insurance card. So once you can bring a person up to that level of knowledge, then you can start to have them understand, well, what is a copay? Is my co-insurance going to be different if I go out of network versus in network? Will I have less of a copay if I go to my doctor versus the ER? And so what they did in Indiana was really create a program for more the single uninsured adults who might be eligible for Medicaid, and brought in those program elements. So creating that kind of structure where if they were to go get a job, they would be more familiar with the cost shares and the co-insurance. Actually, the program also ties into their workforce development programs in Indiana. So there was a lot of interesting things in Healthy Indiana that I think here in Ohio we're looking at to see if they would work here. Other states across the country are considering some of these elements as well. So it'd be interesting to see, again, as we get more data on Healthy Indiana, that SEMA was actually around to help develop, whether or not that becomes an option for states. If Ohio was to do that, we would have to seek approval from the CMS. Prior to that change in administration, Ohio did submit a similar type of waiver called Healthy Ohio to CMS, and this was late last year. That waiver was denied. So the thought is now, so if we go back again to a CMS that now is headed by the Trump administration, there might be an opportunity to have a better dialogue with them about these types of programs. I think the role of the National Association of Health Underwriters and the Ohio Association of Health Writers is really important for consumers. I mean, insurance agents provide invaluable guidance in helping selecting a product that is very, very personal for the individual. I, having worked in the insurance industry, it's not car insurance. It is something that you need to take care of you or a loved one if you need medical assistance, and that is so important. So I think what NAHU brings to that transaction is just someone that consumers can rely on to understand the health insurance market.